Okay, so today we're going to go through the male reproductive system. I'm going to start in lab with the male, and then we're going to do the female reproductive system following. We're also going to do this in lecture, so there'll be a nice opportunity to have some repetition. And then we'll couple this with some cadaver videos that I'm going to shoot, so you guys can look at what we have from the lab in the sense of male and female reproductive structuring. All right, so just the general design, and I realize that many of you are very familiar with the general design of the reproductive system, so hopefully I'll shed some light on some of the details of the structures. But starting off there, for both systems, there are gonads, which are the sex cell and hormone-producing structures. In males, that gonad is the testes, and the sex cells they produce, of course, are sperm. In females, of course, the gonads are going to be the ovaries, and the sex cells that we produce as females would be the oocytes. In males, the hormones are going to be in highest concentration are the androgens or testosterone, and in females, we'll find it's estrogen and progesterone. All right, so males have gonads. Those gonads are sex cell and hormone producing structures. They'll be producing sperm and also testosterone. In addition to producing the sex cells and the hormones that orchestrate their development, we also have to have accessory structuring. Accessory structures are extremely important for a variety of reasons. One is that in the male, we're going to find that sex cell production is going to take quite some time. On average, you're looking at about 74 days or so. Obviously, that'll vary from um, uh, production cycle to production cycle. But you need to be able to nourish those developing sperm during that entire period of time. You also have to store them till an appropriate time for ejaculation. We need to make sure that they're given adequate time to mature. We need to make sure that they're fully activated and that they're protected. Not only protected within the male, we'll talk about the fact that the male's immune system actually will attack their own sperm cells, but also ensuring that they are relatively protected as they are ejaculated into the female. So that's really important as well. And then effective delivery. The male reproductive structures that we tend to associate mostly with the male reproductive system, that being the penis, are actually simply a delivery system. So we'll look at delivering sex cells effectively into the male. Transport is also really important. Sperm cells actually do not swim until they have mixed with seminal secretions and they become bathed in semen. So right at the time of ejaculation is the first time they start swimming, although they've lived for many weeks within the male, moving through the male reproductive system. That's all done by smooth muscle contractions within the male. So transport within the male is also very important. All right, so just a little brief background on the embryonic origin of reproductive tissue. Males and females have an extremely high amount of homology between reproductive structuring, and that's because they are developing from the same embryonic tissue or mesoderm. Differentiation starts at about 4 to 8 weeks, where we start to see cells deriving toward and moving toward being male and being female. This driving force is going to be initiated by the Y chromosome. It's kind of the default pattern is a female, but if you have a male Y chromosome, then you're going to find that the sex cell tissue, that embryonic mesoderm, is going to start to differentiate into male structuring. So when we look at both males and females, we're going to find that there's always going to be a homologous structure that has a beginning in mesoderm that is the same. So in females, because we don't have a Y chromosome, we don't have the genes that allow for that sexual determination that we see in males. So one of those genes is referred to as testes determining factor. We also don't have the genes for high levels of testosterone binding and the ability to be sensitive to testosterone, so on and so forth. So these are just drawings. This is looking at some of that undifferentiated sex tissue or reproductive tissue, mesoderm. And then when we start to differentiate, you'll notice that the yellow structure here becomes, for example, the male glans penis, and in females becomes the glans clitoris. So we see that homology. We can see the skin over the shaft of the penis here becomes essentially the skin that we call the hood over the clitoris. The scrotum, this fleshy sort of external pouch of skin, is homologous with the labia majora. If we look at this thin frenulum that we see in the male here, that becomes the labia minora. So we see a lot of homology between male and female structures because they're developing from the same embryonic tissue. All right, so focusing more on the male gonad, and I'll take a video and post it of our male reproductive gonads that we have from lab. But looking at male gonads, these are solid structures. Even though housed within them are little tiny tubules, they are so concentrated and densely packed that when you squeeze them or touch them, they're very, very solid. They give a little bit, but they're very solid. They're wrapped in a really thick outside protective layer, so they look white. Size-wise, their length is about 5 centimeters. Their width is about 2.5 centimeters, and their diameter is about 1.5 centimeters or so. So they're ovoid, but kind of flat. And we're going to see that they're located in this external pouch of skin called the scrotum. So that's what we're looking at here. This is an incision into the scrotal skin and then into the structures housed within the scrotum. This sort of ovoid white structuring, that's the testis sitting inside the scrotum. Again, remember, this is where we're going to be making our sex cells. So if sex cells are made in this structure, they have to have an exit route. And so we actually can see that right behind it. That's the vas deferens right there. And we can even see some blood vessels going across the surface of the testis here. If the testis is also making testosterone, that hormone travels not only within the testis, but also systemically. So you can also see the vascular tissue over here that's going to be bringing blood in and out of the testis itself. So we have paired gonads. They sit inside each individual testis, so they're separate from each other. And again, sex cell production, the fancy name of that is called spermatogenesis. The sperm are called spermatozoan or spermatids, and they will be produced at an insanely fast rate within the reproductive male. We look at about a rate of 30 to 500 million sperm can be produced in a day. That's about 1,000 sperm, sometimes upward to 1,500 sperm a second. That's crazy. So again, it takes about 7 to 9 weeks, depending on the individual. They'll spend about 5 weeks within the testis, another 20 some days within the epididymis. So you have quite a significant amount of time residing in this external pouch of skin of the scrotum. All right, quick little video on male reproductive.
The primary role of the male reproductive system is to produce and deliver sperm to fertilize an egg in the female. These sperm are produced outside of the body cavity by the testicles, which are located in the scrotum. The scrotum protects and supports the male reproductive organs that are located outside of the body cavity. These include the testicles, epididymis, and vas deferens. The testicles produce about 300 million sperm each day. However, this is possible only if the temperature of the testicle is 93.2 degrees Fahrenheit. The scrotum maintains this temperature by adjusting how closely it holds the testicles to the body. The interior of each testicle consists of multiple lobules containing 2 or 3 seminiferous tubules. It is within these tubules that sperm formation begins. The sperm moves out of the tubules into the epididymis and then into the vas deferens. The vas deferens carry the sperm upward into the body cavity. After the sperm leaves the vas deferens through the ejaculatory ducts, they pass the openings of the seminal vesicles. The seminal vesicles, which are located near the base of the ejaculatory ducts, secrete a thick yellow substance to nourish the sperm. This secretion forms 60% of the volume of the semen. Semen is the sperm-containing fluid that is ejaculated at the climax of male sexual excitement. From here, the semen travels into the 8-inch long urethra, which transports both urine and semen, but not at the same time. At first, The urethra is surrounded by the prostate gland, and then it is surrounded and protected externally by the penis that is relaxed except during sexual excitement. During sexual excitement, the penis stiffens and enlarges so it can deliver the sperm into the female vagina. During the expelling of the semen, which is known as ejaculation, the prostate gland secretes a thick alkaline fluid that increases the ability of the sperm to move in the semen. Located just below the prostate gland are the bulbourethral glands. These glands open into the urethra, and during sexual arousal, they secrete the pre-ejaculate fluid that flushes out any residual urine from the urethra. It also lubricates the urethra to help the sperm pass through. When the male ejaculates into the vagina of the female, the sperm must travel upward through the uterus to fertilize the egg in the fallopian tube.
Okay, so testis composition. When you're looking inside of the testis, you're going to have about 250 individual sort of compartments they call lobules. Within those lobules are these very teeny tiny coiled tubules. These little tiny coiled tubules are called seminiferous tubules, and this is actually where sperm formation occurs. In the male, and you have approximately half a mile of seminiferous tubule length, which is crazy. But remember, if you're going to be making on average 300 million sperm a day at about 1,000 sperm a second, you have to have a very large surface area. So we have lots of teeny tiny tubules. Within those 250 lobules, they estimate there are about 750 or so tubules. When we look at one of those little tubules in cross-section, we'll notice that around the outside edge are what we call spermatogonia. These are sex cells that have 46 chromosomes that are resident throughout the male's entire life. These resident spermatogonium will always go through a process of mitosis first, and then they'll go through a process of meiosis after. So the mitotic initial division is to make sure that they always have a resident number of spermatogonium. So when sex cell production is initiated, we'll see a mitotic division to make two spermatocytes, and then one of those will stay as a spermatogonium, and the other one will go through meiosis to produce 4 sex cells. So for males, which is crazy, males can be reproductively efficient all the way into like their 70s, where females' reproductive lifetime usually significantly reduces by the time they're 40 years of age. And between 40 and 50, we see very high levels of fertility issues starting at about, well, really 35, but between 40 and 45, you see your reproductive ability significantly declining. So females' reproductive life is easily half what males are. And one of the reasons for that, we'll look at this a little bit later, is that female sex cells have been resident within the female since before she was born. And in males, we don't actually start sex cell production until puberty, and it's an ongoing process of new sex cell production every day. So in males, the process of sex cell production is called spermatogenesis, and that occurs within the seminiferous tubules. So again, when we look at the cross-section through the testis, you're going to see that it's divided into about 250 lobules. The lobules are these little spaces that are partitioned by what we call septa. And then the outside surface, like I mentioned, is really thick white connective tissue that's very protective. That's called the tunica albuginea. And the reason it's called that, tunica just means the layer, and albule means white. So I remember when we were looking at our anterior musculature in the abdomen, we had the linea alba, so alba meaning white there. Here, tunica albuginea means the white, thick covering over the testis. And these will expand into those little divisions or septa. All right, so this is a nice drawing of what that would look like. So this is a mid-sagittal section through a testis. You can see the really thick outside covering, that's the tunica albuginea. When you're dissecting, you have to use a scalpel to cut through that because it's extremely thick. And then you could see it going down into the septa here. So these are the septa. And then housed within the septa, this space here is the lobule. And then moving back and forth and back and forth, these little tiny tubules, those are the seminiferous tubules. Okay, so we have about 250 lobules within each testis. You have about 700 to 800 seminiferous tubules housed within the testis itself. And when we're looking at the cross section through one of those, we're going to see that this is the location of spermatogenesis. This drawing over here is trying to show you the tubules themselves and kind of the route through which sperm would travel. So we're going to see that within a lobule, the seminiferous tubules are going to kind of drain toward this central depository. This is called the rete testis. You can see all the seminiferous tubules are going to drain into that rete testis. Again, remember, rete or rete testis, this means network. So this is the network inside of the testis that's going to collect all of the sperm that are fully formed but not yet mature. And then they're going to drain the testis into these ductules here. These are exiting ductules, so we call them efferent ductules. In anatomy, we use this term quite often. Efferent means exiting or moving away from. So these are the efferent ductules that will carry the fully formed but not yet mature sperm into a structure called the epididymis. The epididymis is a place where sperm are going to reside for several weeks, upwards to 20 days or so. And the epididymis, if we were to stretch it out, this is going to be about 6 meters of length. And this is where we're going to allow those sperm to sit and mature, becoming competent for fertilization and motility. So that's a really important location. So from the lobules, seminiferous tubules, we move into the rete testi. From the rete testi, we go into the efferent ductules, and then we go into the epididymis. And all of this is housed within the scrotum. All right, this is a really nice histological image of a cross-section through one of those seminiferous tubules. You can see there's very little space between the tubules. These are solid structures as well. There's not much space in the center. The majority of the diameter across the seminiferous tubule is actually cells in the process of meiosis. Around the outside border, these darker nucleated cells, those are the cells that have 46 chromosomes. So those are the spermatogonium. These are resident within the male from the time of birth, but they're not going to be active in the production of sperm until after puberty starts. And when puberty starts, we're going to see that these spermatogonium are then going to start to undergo meiosis. That'll be initiated by follicle stimulating hormone released from the pituitary gland and the presence of testosterone produced by the surrounding Leydig cells. We're going to see that production of sperm will occur from the periphery toward the center. So if we're watching meiosis, it's occurring from the periphery down toward the center. That's why the lumen here is filled with essentially all these little flagella. So these little very tiny dark spots, those are the spermatozoa heads. And then the lines here, those are the flagellum or tails. All right, so when we look at the spermatogenesis through the microscope, we would see that the outside edge, so what they're trying to show here is the connective tissue of a single seminiferous tubule. So this would be fibrous connective tissue. There's also some smooth muscle associated with it. We could see the blue cells here. These are the cells that would develop into sperm. So these outside larger cells, those are the spermatogonium. And then as we're looking down toward the center, we're watching essentially the process of meiosis or spermatogenesis, where in the center of the lumen of the seminiferous tubule, we're going to see the spermatozoa. Again, depending on where you look, the number is going to vary slightly, but usually we say between 30 and 500 million sperm a day. So you can see a bigger bracket. I have here 50 to 300 million a day. Production rates are somewhere between 1,000 to 1,500 sperm a day or sperm a second. So we're having really, really fast production of sperm. So the reason we have so many sperm produced per second or per day is because of the surface area. So we have this tremendous network of seminiferous tubules that's moving throughout. So remember, you have about 750 of these tubules jam-packed within the lobules. The maturation time can be upwards of 70 some days. So it's going to be quite some time that they're going to be resident within the reproductive system of the male. But the production rate is super fast. All right, so quick video on spermatogenesis.
The testes constantly produce sperm, the male sex cells. Production begins within the seminiferous tubules, where stem cells, called spermatogonia, develop into immature sperm. Each 46 chromosome spermatogonium divides through mitosis to produce primary spermatocytes. These cells divide by meiosis to become 23 chromosome cells called secondary spermatocytes, then spermatids. This multi-step process, called spermatogenesis, produces the 23 chromosome immature sperm cells that mature in the epididymis.
Okay,
The
so
testes
there we go. So this is looking at one of those little seminiferous tubules here. This is a histological image. So again, this is a little bit better because we can see the connect tissue and some smooth muscles. So we have myometrial cells out here. We have the spermatogonia, which are these large nucleated cells. We have spermatogonia there. So these spermatogonia are going to divide first through mitosis and then through meiosis to eventually produce the spermatids or spermatozoa. These guys are very tiny, so there's a significant reduction in size. These spermatozoa end up being about 1/100,000th the mass of an egg cell. So they're super teeny tiny. And an egg cell is about 1/10 of a millimeter, and spermatids are about 1/100,000th the size of an egg. So very teeny tiny. They're sort of the stripped down version. They really carry very little. It's simply the 23 chromosomes from the male, which we are going to be jam packed in these teeny tiny sort of conical shaped nuclei, and then they have very little organelle except for a lot of mitochondria that will be powering their flagellum. All right, so in addition to the spermatogonium and the cells in varying stages of meiosis, we also have another cell sitting within the seminiferous tubule, and these are called Sertoli cells. Sertoli cells, also referred to as nurse cells, are really important. One of the things you're going to find, and this is just a nice drawing of that. So here again, these darker staining cells out here, these are spermatogonium. And then we see a large cell here with sort of a, where are they? They have them labeled. Well, these guys, large cell here that have a lot of cytoplasm around them. So these guys, these are called Sertoli cells or nurse cells. These function to protect the male dividing sperm cells. And so here's the crazy thing, crazy story. Males do not produce sperm until puberty is initiated, but your immune system develops when you're a child. So our immune system develops competence before the male system ever has sperm cells present. Now they'll have spermatogonium, but they won't have spermatids. And so for the male, when their immune system is trying to figure out what is a cell that belongs to them and what cells are foreign, they don't have the ability to see sperm cells in that capacitation process. So once puberty is initiated, they now have in their body a cell that would be considered foreign to their own immune system. So the function of these Sertoli cells or nurse cells is multiple fold. So one of the things they're going to do is form what's called the blood-testis barrier. I know a lot of you have heard about the blood-brain barrier, so it's very similar. They form basically a cytoplasmic wall between circulating blood and the developing spermatids, so that the male immune system doesn't have direct access to the spermatids, and therefore the immune system in the male will never mount an immune response to the spermatids as they're forming. So these Sertoli cells will have gap junctions between them, so they'll be all interconnected. So if we could look, there'd be a sort of this cytoplasmic wall produced by these Sertoli cells that goes all the way around. And then in addition, if you're creating a sort of a vascular wall where you're not going to allow, or I say a vascular barrier, where you're not going to allow blood diffusion to occur directly to your spermatids, they would starve to death. And so the nurse cells or Sertoli cells will in fact also distribute respiratory gases and nutrients to the developing spermatids. So spermatids are reliant on the presence of Sertoli cells to sustain them. So that's a really important function. So the Sertoli cells or nurse cells, these are the guys that have kind of really large nuclei and a lot of cytoplasm around them. Okay, so when we look here, here's another one out here, there's another one out there. And so they kind of form these cytoplasmic connections. All right, so this is Sertoli cells, aka nurse cells, also called sometimes sustentacular cells. Here we're trying to show you one of those gap junctions. So here they're creating this cytoplasmic wall that separates not the spermatogonium. So these are spermatogonium. These are present since a male's been an infant, but we want to make sure that the dividing or meiotic cells are going to be protected. So as soon as you start to go in meiosis, you're creating cells the male immune system's never seen. And so these are the cells we need to protect. So I thought that was really cool. It's really important to make sure that males don't have any reproductive bleeds because if you have a testicular injury, that can actually render a male infertile if you have a blood vessel bleed into the testis and you have the immune system starting to get exposed to your sperm cells. All right, so last but not least, in the testis, of course, we have not only sperm formation, but we also have testosterone being produced. And that's produced within the testis in areas that actually exist between the seminiferous tubules. So if we look between the tubule here, we have this tissue between the tubules, and so they actually called it interstitial, meaning literally between the tissue, or Leydig cells. And so the Leydig cells or interstitial tissue house blood vessels and testosterone producing cells. So this is a histological image where we have a seminiferous tubule here. We have all that spermatogenesis occurring toward the interior. And then on the outside surface, out in here, this is where we're going to have our Leydig or interstitial cells. So these guys are going to be making testosterone that will diffuse not only into the seminiferous tubules, where it can bind to androgen binding proteins by Sertoli cells, and then they will make sure that there's a high concentration of testosterone present, but also into surrounding blood vessels and then carried away to systemic circulation. All right, so essentially we're done with looking at the testis, and I will have a cadaver video where we're going to look inside the testis at these little tiny seminiferous tubules. The seminiferous tubules, remember, are sitting within these little lobules. You have about 250 of those lobules that then drain into what we call the reedy testi. The reedy testi or reed testi will collect all of the sperm that are fully formed and not yet mature and drain them from the testis into our next structure, which is called the epididymis. These tubules that drain are exiting the testes, so we call them efferent ductules. And then the epididymis, epi meaning above, we've seen that term a lot. Epididymis kind of has a cool name. Didymis refers to twins, and so what they're talking about is this structure that sits above the twins being the testi. So the reedy testi drains seminiferous tubules into the epididymis through the efferent ductules or efferent ducts. And then the epididymis, which sits here, is about 6 meters or about 13 feet of length. Again, we're going to sit there for easily 2 weeks and upwards to about 20 days. And this is really where we get the majority of maturation occurring. The cells of the epididymis are going to be our pseudostratified ciliated columnar epithelial cells that have stereocilia. You guys remember the stereocilia? They kind of look like cilia, but they're really long and they don't move. The stereocilia are more like microvilli. They're really long, and that allows you to have a really high surface area into the center of the epididymal space, and that's for exchange. Remember, sperm are not moving yet. They don't have a lot of storage structuring within them, so they're going to be very reliant on the epididymal fluid to support them nutritively with respiratory gases so they can maintain their metabolism. They'll also have maturation factors. and they will also be recycling. So we have a lot of turnover. So any cells that get formed that are not adequate in that formation, we're going to see they will attrige and they'll break down, and we'll see them being reabsorbed by the epididymal cells. So very important location for maturation to occur. So you're looking at anywhere between 2 weeks to 20 days or so, sometimes even longer, depending how often ejaculation occurs. All right, so from the epididymis, this is all again located within the scrotum. We now are going to exit the epididymis into a single tube that will then exit the scrotum and go into the body in order to be ejaculated. This single tube that is going to exit the epididymis and travel up into the body is the vas deferens or ductus deferens. It's easily about a foot in length and will travel through a gap in the anterior abdominal wall just above the pelvic brim to enter into the body cavity. The epididymis and the vas deferens are going to be primarily a really thick layer of smooth muscle that makes up that tubule. In fact, if you do a cross section through the through the vas deferens here, it almost feels solid. There's a very teeny tiny lumen. Remember, spermatids are 1/100,000th of that tenth of a millimeter size. So they're very, very, very small. So you're looking at essentially a millionth the size of a millimeter. So these guys are going to basically be pushed up this tube. We want to make sure that the tube lumen is very tiny to create the pressures required to navigate those sperm. They're not swimming, so to push them peristaltically through that approximately foot-long length of tubing. The gap in the abdominal wall is called the inguinal canal, and remember that area in the body is called the inguine. So this is going to be a gap in the abdominal musculature between the fascicles of the abdominal muscle. All right, so we looked at this already. So this will be just review. Remember, you have this tunica albuginea, this really thick outside covering that then goes into the testis to divide it into lobules. So these are the septa. And the lobules are your seminiferous tubules. The seminiferous tubules drain into the rete testi, that then drains into the efferent ductules, that goes into the epididymis, and then the epididymis converges into the vas deferens or ductus deferens. Okay, so this is looking at the male reproductive system from the anterior view. So you're looking at the anterior pelvic wall here. You can see the two testes sit within their own individual scrotal spaces. And there's a frenulum that divides the scrotum into the two scrotal cavities. We can see here this gap is actually the inguinal canal. You can see that on both sides. It's very palpable, so if you palpate the anterior pelvic wall here, you should be able to palpate this structure as it transverses from this external location, or transfers from this external location to an internal location. This collective structure here is called the spermatic cord. It's surrounded by essentially skeletal muscle, but it's going to be autonomically innervated. This skeletal muscle here is actually from the internal abdominal oblique muscle. So you have fibers from the internal abdominal oblique that are going to come through the inguinal canal and then surround the entire spermatic cord and testi. On this side, they cut through that muscle. That muscle's name is called the cremaster muscle. And they're cutting open the spermatic cord so you can see inside. And this thick tube here, again, you can palpate this. You can feel it. It's really solid. Is the vas deferens. And then next to it are going to be the blood vessels. You'll have the testicular artery and then the network of testicular veins and also testicular nerve, all in the spermatic cord. Okay, so, and then we can also, see here we opened up the scrotal cavity and you can see the testis itself. Remember, it's really thick white covering here, that tunica albuginea, and then peeking over the top, this is the epididymis. So we're going to see that it has this sort of head or caput, and then there's the body that runs around it, and then it ends at the inferior component and becomes the tail, and then the vas deferens, which then comes out. All right, so next is really quickly looking at the scrotum. I think the scrotum gets passed over as not having really an important function. Anatomically, there's not a whole lot to the scrotum in the sense of structuring. It's a very thin-walled external pouch of skin. It's thin-walled in the sense of the amount of adipose tissue, the thickness of the skin, the amount of hair, and the amount of dermal tissue. So it's very thin-walled, very low insulation. So again, there's very little adipose tissue in the subcutaneous, very little hair across the scrotum. And the reason for all of that is you want the scrotum to dissipate heat. You want it to give off heat really easily. You don't want it to contain or collect heat. Um, the reason for that is because spermatogenesis, where we're taking a spermatogonium and we're reducing it to a very teeny tiny cell, that reduction process is very temperature sensitive and we don't want it to occur too quickly. So it has to occur at about 3 to 4 degrees below body temperature. Depending where you look, the averages are a little bit different, but essentially slightly below body temperature. In order to make sure that's the case, you have to house the testis outside the body cavity. If it were inside the body cavity, it'd be too warm for adequate spermatogenesis to occur, and you get malformed sperm that are not capable of fertilizing. So the testes have to be located in this external pouch of skin. That external pouch of skin has to be able to dissipate a lot of heat, especially because you have a testicular artery coming in that's warm blood. You want the heat to get dissipated. In order to make sure that the testis, depending on what the individual is doing, always stays about the same temperature, we're going to have to be able to move that testis closer to the body or farther away from the body, depending on the external temperature and also the body temperature. So if a guy goes for a run and they generate a lot of metabolic heat, you're going to find that that metabolic heat will cause the testis to also get too warm. And so in order to ensure that we get adequate heat loss, you find that the scrotum should sit farther away from the body. We have 2 sets of muscle that regulate the positioning of the testis. There's a cremaster muscle, which is the one I mentioned. It's part of the internal abdominal oblique. That's this guy right here. The cremaster muscle comes down and around the spermatic cord, and then all the way around the testis and back. So that cremaster muscle functions to contract and literally pull the testis up toward the body cavity, or relax and allow it to fall away from the body cavity. So if you're exercising, you're going to want that cremaster muscle relaxed so that the testis is lower and farther away from the body, so it's not going to get too warm. And then we also have another muscle called dartos muscle that's literally within the underlayers of the dermis. So when you're looking at the skin, you have it associated with the dermis. So it's right at that level of where the subcutaneous is and the underlayers of dermis. The dartos muscle functions to gather the dermis. And so when the dartos muscle contracts, you're going to see it kind of gathers the scrotal skin. And if someone's cold, you'll notice that the scrotal skin get very folded. And that's because the dartos muscle is contracting and gathering the scrotal skin together and really kind of making the internal space in the scrotum smaller and pushing the testis up. So it's a really cool system to ensure that we can have adequate temperature regulation of the testis. So again, we have dartos tunic, which is part of the skin. It's the underlayers between the subcutaneous and the dermis. And then we have cremaster muscle, which is part of the interabdominal oblique that comes through the inguinal canal, down the spermatic cord, and wraps around the testis. Last but not least, to make sure that we have adequate temperature regulation, remember the testicular artery is coming out of the body cavity, so it's nice warm blood. So whatever the body temperature is, 98.6, that's this nice arterial blood coming into the testis. So we need to make sure that blood cools before it actually hits the testis. So as the testicular artery comes down through the spermatic cord, it's going to run past all of this network of returning blood vessels or venous vessels. These guys would have been just now returning from the skin, where you have a lot of heat dissipating, And so the venous blood that's returning is going to be really cool compared to the testicular arterial blood coming in, which is really warm. And so you actually have a counter current blood flow occurring, which allows for a transfer of heat. So the cool venous blood will actually get warmed by the incoming arterial blood. That means that the incoming arterial blood into the testis will get cooled. So as that testicular blood coming in through the testicular artery travels around the testis, it's now going to be cool by the time it gets to it. So this network of venous return is actually called the pampiniform plexus. Pampiniform plexus means that you have these little tiny filaments of blood vessels. Okay. All right, and then just side note, cremaster, which is kind of a cool name, means suspender. So it functions just like, if you were pulling your pants up with suspenders. So it pulls the testis up. And dardos means filleted. So if you're filleting an animal, usually you're cutting the skin off, and dardos is present in the skin. All right, so these are examples of the cremaster muscle. So this is the inguinal canal. It's that gap in the anterior abdominal wall. This is the internal abdominal oblique muscle coming down around the spermatic cord and then laying down around the testis itself. So this will pull the testis up. Just a side note, just like some people can wiggle their ears, some males can actually have some innervation still to these fibers here. Remember that the nervous system innervates the fascicles. We don't actually have conscious innervation, at least most people don't have conscious innervation into the skeletal muscle fascicles. Usually it's autonomic innervation, but some males can have a little bit of innervation still left, and so some males can actually move their testis. Just kind of a cool, fun trick, I suppose. All right, so when we look at the inguinal canal coming out, this whole structuring is called the spermatic cord. And inside the spermatic cord, you're going to have the vas deferens or ductus deferens. That's this guy right here. Again, you should be able to feel that if you're feeling the anterior body wall here, or lower in the scrotum, you can sometimes feel the vas deferens. In fact, when they're doing vasectomies and you're trying to render a male infertile so that you don't have any more kids, they'll actually cut through the back wall of the scrotum and snag essentially the vas deferens, because you can actually grab it. It's a pretty solid structure. And then you just pull it out, and you can either ligate it, tie it, you can cauterize it, or you can cut it. And that will then not allow sperm to exit the scrotum and into the body cavity. Anyway, so you have the vas deferens, you also have the testicular artery, you have the pampiniform plexus, and then you have the testicular nerves. Those are all things located in that spermatic cord. So on this side, they have spermatic cord left intact, and on this side, they have it open. All right, and then this is just another artistic rendering of that. So here we can see this is vasculature in the inside of the pelvis. So we have what's called the external iliac vessels, and we can see this is a branch, comes off and goes through this gap in the fascicles of the abdominal muscle. And we can see the testicular artery coming in. We also see this amazing network of vasculature for returning vessels. So we can see it going into the internal saphenous and then also going up into the external iliac. So this is this returning venous blood. So this is what we call a pampiniform plexus. All right, layers of the scrotum. This is actually kind of a cool structure. So basically you have the skin of the scrotum. So that's what we're looking at here. So this is the skin of the scrotum. Remember that dardos tunic actually sits on the undersurface. So kind of where the subcutaneous is and the underlayers of dermis, that's the dardos right there. Scrotal fascia, so this is like subcutaneous scrotal fascia. And then we have surrounding that. So the scrotal fascia is kind of cool because that gives you that kind of squishy, soft layer. So it's somewhat distortable, movable. This is the cremaster muscle coming down and around the testis. And then you have sitting inside of this, you have the testis itself. Now the testis has to be able to move, so it's in a cavity. And of course, lining that cavity is going to be a visceral and a parietal layer. So I should say a parietal layer lining the cavity. So that's this right here. So that's the parietal layer. And then we have a visceral layer actually covering the testis, so the testis can move. So this is technically the scrotal cavity where the testis is located. We have it lined with a parietal layer. Then we also have it, the testis covered with a visceral layer. Now this layer of serous membrane, so it's just serous membrane, it actually comes from the parietal peritoneum. We pull the testis down through the inguinal canal. They call it the tunica vaginalis. I remember when I first learned that, I thought that was a mistake. And it's not. Vaginalis means sheath. So it's basically you're going to take the testis and you're going to pull it through the parietal peritoneum. And as it comes through, it's going to get covered. And then we're also going to have that lining of the scrotal space. So vaginalis just means sheath. So we have the parietal vaginalis and the visceral vaginalis, basically the serous membranes that line the scrotal space and then cover the testicular tissue. And then just underneath that, we have this really thick white layer, that's the tunica albuginea, and then the septa. Okay, so I have here basically the layering with scrotum. We're going to have the skin, dartos muscle, and scrotal fascia. So again, scrotal fascia is kind of like the subcutaneous. We have the muscle attaching to the undersurface of the dermis on the skin, so we can gather or furrow the scrotal skin for moving the testis up by making the scrotal space smaller. Cremaster muscle, which is part of the intra-abdominal oblique surrounding and pulling the testis up. Then we have the tunica vaginalis, which is the visceral and parietal layer, parietal lining the scrotal space, visceral layer covering the testis. And then we have the really thick protective covering called the tunica albuginea. And this layer is essentially going to cover and protect the testis. Remember, we want to make sure that the testis is protected because we don't want to have any bleeds within here. Obviously, this tissue has to be vascular. You can even see blood vessels coming in here, but we want to make sure that we don't have bleeds into the seminiferous tubule. So it's one of the reasons we have this really thick outer covering of the tunica albuginea. It helps protect the testis from injury. All right, vas deferens. We can see here the vas deferens leaving the scrotum and going over the pelvic brim here. It's going to be retroperitoneal, so it's underneath the parietal peritoneum in the abdominal floor. It's going to be between the bladder and the parietal peritoneum. It goes over the surface of the bladder all the way to the posterior of the bladder. Back here, we're going to have the vas deferens enlarge a little bit into what we call the ampulla. And then it's going to join into the prostate with these two large lateral glands called the seminal vesicles. Okay? So it's going to enlarge into the ampulla and then it's going to merge within the prostate along with the seminal vesicles. It's made up of, like I mentioned, a lot of smooth muscle to help allow for peristalsis. Remember, sperm are not yet swimming. And then also we have a lot of stereocilia. Again, for that same reason, we want to nurse the sperm during the period of time that they exist within the vas deferens. All right, so I already mentioned this. Within the spermatic cord, we have the vas deferens, testicular artery and vein. The veins are going to be classified as the pempiniform plexus, testicular nerves. Okay, so in lab, I'll take a quick video so we can actually look at the spermatic cord structuring within the male. All right, so now we're into the accessory glands. This is a view from essentially the posterior aspect of the bladder. So this is the posterior side of the bladder. This is the front of the bladder. These are the ureters. So remember, the ureters are going to come in also to the posterior aspect of the bladder. And these structures here are kind of looping over the ureter. And this is actually one of the ways you can figure out where you are, is this cross right here. This is the vas deferens from either side coming in. So this is the right vas deferens. This is the left vas deferens. Becoming enlarged here is the ampulla. So we have two ampulla on either side. And they're going to then come in alongside these two seminal vesicles into the prostate. So when they go into the prostate, there's going to be what we call the ejaculatory ducts that merge the seminal vesicle fluid and the sperm cells coming from the vas deferens. So we have epididymal and vas deferens fluid coming in here into the prostate. The accessory glands are going to make essentially the majority of what is semen. Only about 10% of semen is actually sperm and epididymal fluid. So the majority of what is semen is actually coming from our accessory glands. The most productive of those is actually the seminal vesicles. They make about 60% of seminal fluid. A single ejaculant usually is somewhere between 2 and 5 mils of ejaculant. Obviously, that varies a whole lot on so many things. It will vary depending on the hydration state of the person, the level of stress in that individual's life, how many previous ejaculants they have had, how often they typically ejaculate, the age of the individual, the overall health of the individual, the blood pressure of the individual. There's so many things that can affect ejaculate volume. But on average, you're looking at 2 to 5 mils or tablespoon of ejaculant. And in that ejaculant, again, you have somewhere between 30 and 500 million sperm. On average, it's about 300 million. And just side note, if you were considered infertile, you would have less than 20 million per mil, which to me is like, how can that be infertile? If you have 20 million per milliliter, that's technically considered infertile because you need a huge number of sperm to be able to navigate the female reproductive system. It's about 8 or 9 inches within the female that sperm are going to have to travel. And you need a huge number of them to finally meet the egg. So you may ejaculate 300 million, you may only have a few hundred sperm that finally make that distance of meeting the egg. All right, so functions of the accessory glands, lots of functions. They do many, many things. Remember, the sperm are not swimming, so one of the things that the seminal glands are going to do is they're going to add activating factors that activate the motility of the sperm. They're also going to activate the capacitation abilities so that they'll be able to fertilize. They're going to provide nutrient. They're going to provide clotting factors. They're going to be very alkaline to protect women and the female. They have citrate that helps to activate. There'll be zinc that helps to stabilize DNA. Just a lot of functions of the seminal fluid. So I have here activate sperm motility, provide nutrients, protect sperm, sort of as a general overview. All right, so seminal vesicles, these guys are paired glands on either side. They kind of look like the pancreas in the sense that they're lobulated and they're kind of whitish in color. They're quite large. They're about 4.5 centimeters long, but they're flat. So they're only about 0.5 centimeter in thickness, but they're pretty big. And they sit laying on the back side of the bladder, just lateral to where the ampulla come in to the prostate. They make the majority of seminal fluid. What people probably remember is the fructose that is in semen. They make the majority of the fructose, which is a simple sugar that helps to fuel the sperm when they're in the ejaculate. It's very alkaline. The female reproductive system is very acidic, so it helps protect them against that female acidity. Clotting factors. When semen is ejaculated, it will start to clot, which increases the viscosity, which helps to keep them within the female reproductive system. You'll have some female immune suppressors, so the female immune system doesn't immediately attack them, so they can actually have a chance to start to migrate. So those are all functions, and also things like prostaglandins, many other things, citrate, those are all things released by the seminal vesicles. This is a mid-sagittal view of the male pelvis. So here we see the bladder sitting just posterior to the pubic symphysis and anterior to the rectum and superior to the prostate. And we see a little bit of the seminal vesicle here, and we're looking at the ejaculatory duct. So the ejaculatory duct here is going to carry the fluid from the seminal vesicle as well as the fluid coming from the ampulla of the vas deferens. So we're looking at sperm coming in with epididymal fluid, and then a tremendous amount of fluid coming from the seminal vesicle traveling through this ejaculatory duct. All right, the prostate is about the size of a walnut. This guy is about 2 by 3 by 4 centimeters. It makes approximately 20 to 30% of seminal fluid. It produces prostaglandins, and that's actually where the name prostaglandin came from. But that's not its primary secretion. In fact, prostaglandins are made by almost every tissue in our body. But prostaglandins are going to help to initiate sperm activation and augment motility. It also has zinc, which helps to stabilize DNA. It also is very alkaline, has enzymes to support activity. So lots of different functions for the prostate as well. In fact, most of the prostatic secretions are still not quite sure what they all do. But again, traveling through the prostate, this is going to be the ejaculatory duct. And then right through the center of the prostate is actually the prostatic urethra. So this is actually going to be carrying urine. If a male is urinating, they urinate right through their prostate. So there's this prostatic urethra that travels through. Remember, the inner urethral sphincter is right up here. This is smooth muscle, and this will close off the bladder so that you can't urinate when ejaculation is occurring. And this is the inner urethral sphincter, right at the base of the male erectile tissue. All right, so again, this is looking at the posterior view of the bladder. So again, we have our 2 ureters coming in to the bladder carrying urine. Looping over them and moving medially is the vas deferens into the ampulla. And then we have the 2 very large seminal vesicles, all coming into the ejaculatory ducts. There'll be 2, one on each side, that open up into the prostate. This is a frontal section, so we're cutting into the bladder. So this is the bladder above. Notice the trigone here. Those are the ureteral openings and urethra. That's the trigone. We see the prostate immediately underneath, and we see the prostatic urethra. We see all these little tiny holes here. These little tiny holes or apertures are ductules of the prostate. And then we see this central hole here. This is actually a vestigial, well, they actually say it's a vestigial of the female uterus, but it's actually a blind sac. So this actually doesn't go anywhere. But on either side, here and here, those are the ejaculatory ducts. You have 2 openings. Those are the ejaculatory ducts. All right, so actually, let me see. Oops. Oh, there it is. Oh, so I just want to mention, this is that little tiny vestige of the prostatic, what do they call it? The prostatic vestibule, I think. Anyway, it's a blind sac, and there are some that hypothesize that this is the equivalent of the female uterus. Anyway, all right, so just a teeny bit on prostate that is clinical. The prostate is a gland that is very responsive to testosterone and produces secretions throughout the male's life. But one thing we find is that the prostatic cells, as the individual age, can start to divide and produce what we call benign prostatic hyperplasia. This is quite prevalent and very common in males as we age. In fact, 50% of males will experience, by the time they're 50, benign prostatic hyperplasia. By the time they're 70, about 80% of them will experience benign prostatic hyperplasia. The biggest problem with this is complications with urination. So you can see here, here's the prostate with a normal passage through the prostate. So the prostatic urethra has a normal width, but as the prostate enlarges, it can actually collapse the prostatic urethra, thereby decreasing urine flow. It also pushes up on the bladder, so it causes frequent urination. So you feel like you have to go to the bathroom all the time. Biggest problems with this are obviously incontinence. You have an inability to hold urine quite as well. You have slow urination because you're holding urine and not completely voiding when you urinate. You also typically find increase in urinary infections and sometimes urinary stones. All right, so this is a quick video on that.
If you have benign prostatic hyperplasia, or BPH, your prostate gland is enlarged. The prostate is a walnut-sized gland in men. Just beneath your bladder, your prostate gland surrounds your urethra, the tube through which urine and semen exit your body. Your seminal vesicles and prostate make fluid that combines with sperm cells to create semen. During normal urination, urine flows from your bladder through the part of your urethra inside your prostate, then through the rest of your urethra to leave your body. For unknown reasons, your prostate gland may enlarge as you get older. If you have benign prostatic hyperplasia, your prostate may grow large enough to narrow or block the part of your urethra that runs through it. As a result, your enlarged prostate may slow or block the urine flow out of your body when you urinate. The symptoms of benign prostatic hyperplasia include frequent urination or urge to urinate, especially at night, a weak or interrupted urine stream, and straining to urinate. Over time, untreated benign prostatic hyperplasia may cause the following complications: inability to urinate, damage to your bladder and kidneys, bladder infections, bladder stones, and urine leakage called incontinence. If you have benign prostatic hyperplasia with mild or no symptoms, your doctor may recommend watchful waiting, which includes getting your prostate checked every year to make sure your symptoms or health are not getting worse. If you have moderate symptoms that bother you, your doctor may recommend medication, such as alpha blockers. Alpha blockers relax muscle tissue in the neck of your bladder and in the urethra to improve your urine flow. 5-alpha reductase inhibitors may also improve urine flow over several months by reducing the size of your prostate. You may receive a combination therapy of both types of drugs. If medication isn't relieving your symptoms, your doctor may recommend a surgical procedure called transurethral resection of the prostate, or TURP. During this procedure, your surgeon will insert an instrument called a cystoscope through your urethra to reach your prostate. Then a wire tool called a resectoscope will be inserted through the cystoscope to shave off tissue, which will widen your urethra. Other minimally invasive variations on this type of procedure use lasers, microwaves, radio waves, or electrical energy from tools inserted through the cystoscope to remove some or all of your prostate gland. If your prostate is very large, your doctor may recommend an open prostatectomy procedure. In open prostatectomy, your surgeon will make an incision in your lower abdomen. After exposing your prostate, your surgeon will make an incision in its outer capsule. Next, the tissue inside your prostate will be removed, and the capsule incision will be closed with sutures. Finally, your skin incision will be closed with sutures or staples. You can't prevent benign prostatic hyperplasia, but the following lifestyle changes can make your symptoms less severe. Avoid medication that can make it harder for you to urinate, such as antihistamines and decongestants. Stop drinking fluids for a few hours before bedtime. Avoid drinking alcohol or fluids that contain caffeine. Try to empty your bladder by double voiding. To double void, urinate, wait a few minutes, and then try to urinate again.
Okay, and then last but not least, just a little bit on prostate with how we age. Again, remember, if you're looking at size-wise, it starts off at about the size of a walnut. And then as you age, you can see here by the time you're 40, it may be the size of a golf ball. And then by the time you're 60, it may be the size of a lemon. And then by the time you're 80, it may be the size of a large baseball. So again, we look at prostate growth as merely at this point a problem with incontinence, but can put you more at risk of bladder infections and so on and so forth. And definitely be a problem in the sense of incontinence and things like that. But what's more important is knowing about the prostate cancer. Um, Essentially, the symptoms would be very similar if you were developing prostate cancer. Those symptoms would seem like having difficulty urinating, having a frequent urination. And so if that was the case, you'd want to make sure that you go into your urologist and get checked. Um, Prostate cancer is the second leading cause of cancer death in males. They estimate there are about 30,000 cases a year. So we're looking at a lot of individuals that are developing prostate cancer. One of the most important tests you can do, in addition to just looking at it size-wise, palpating it, or using a sonogram, is the serum test looking at the looking at prostate-specific antigen, or a PSA test. All right, so next is looking at bulbourethral glands. This again is a nice mid-sagittal section, so we can see here, this is again the seminal vesicle. Here's one of the two ejaculatory ducts. We can see the prostatic urethra. And again, you can kind of see this little vestigial structure here, the prostate utricle, I think that's right, utricle, that sits here. And again, this doesn't really serve much of a function. It may contract and help to open the ejaculatory ducts a little bit wider during intercourse and coitus. But other than that, it's a blind-ended sac. You can see from the front here, you can see all these little tiny openings into the prostatic ductules. You can see the two openings here into the ejaculatory ducts. And then again, there's that prostatic utricle, again, that blind-ended sac there. Again, this, they theorize, is the equivalent of the female uterus and may contract and affect the opening to the ejaculatory ducts, making sure they're a little bit wider. Again, this whole structure here is the prostatic urethra. And then we end up going into the penile urethra. On either side of the penile urethra, you can see these little openings here. These are called the bulbourethral glands, or Cowper's glands. Cowper's glands, or the bulbourethral glands, they're actually very aptly named because they're right next to the penile urethra. And this area of the erectile tissue is actually called the bulb of the penis. So they sit at the bulb of the penis and directly empty into the urethra. Their secretion is, for the most part, just a lubricant. It's mucus, very alkaline, that helps to lubricate the penile urethra, helping to make sure that the semen travels really easily through it, as well as lubricate the tip of the gland, so during copulation you have some lubricant. Okay, so urethra, again, is about 8 to 10 inches long, depending on the individual. Again, I'm going to start way up here at the bladder, travel through the prostate, and then travel all the way through the penile urethra to the exterior of the body. It's housed within the erectile tissue here. As you can see, this is what we call the corpus spongiosum. So it's housed within some erectile tissue on the way out of the body. All right. Last but not least is talking about the erectile tissue, which is a really amazing structure of delivery. The male penis is really all about delivering into the female semen as far as you can place it, which is actually right at the female cervix. There's 3 columns of erectile tissue that are going to combine into the depository structure of the penis. There's 3 regions of the penis, though. We have the root, the shaft, and the glands. The root, you can see the 3 erectile tissues. 2 are in purple and 1 is kind of in red here. They function to stabilize the erectile tissue against the pelvis. So literally your penis is attached to your pelvis with fibrous connective tissue. So that's what we call the root. And then the shaft, or the body, is the portion that is going to swell and enlarge and increase the length, the width, and rigidity of the erectile tissue. And then the glans is this sort of soft or squishy erectile tissue that kind of covers the front of the penis. It's very heavily innervated, it's very sensitive, and that's the distal expansion. And this is what the urethra is going to travel out of the penis through. All right, this is out of your textbook. So again, you can see here the pelvic bones on either side. So this would be the root here. We can see in purple these two large columns of erectile tissue. These are called the corpora cavernosa. And then sitting in the center here, this is the bulb of the penis, which is made up of the corpus spongiosum. So collectively, we call this the root. Again, we have the body, and then we have the glands. Okay. All right, so 3 columns of erectile tissue. This is a cross-section through the erectile tissue. The erectile tissue is vascular. So basically you have blood flowing into these big open spaces like a sponge. It'll start to fill those spaces and expand. If we want the erectile tissue to get rigid, we have to expand against a resistant wall of connective tissue. So we can see out here, we have this really thick layer of connective tissue that surrounds the swelling erectile tissue. We have the 2 layers of what we call the corpora cavernosa. Cavernous means large open spaces. So you have a artery traveling right into, so you have the cavernosal artery traveling in. That's going to deposit blood. The venous exit is going to be impeded or inhibited. So the cavernosa will swell with blood and will swell and pressurize this superior space. That's what gives the erectile tissue the length and rigidity. And then in this inferior compartment, separated from the cavernosa, is the corpus spongiosum. So you'll notice it has a very large hole in it, and that's the actual penile urethra through which sperm are going to be moving. What's important about this is that the corpus spongiosum, and corpus just means body, corpora is plural, corpus is singular, is that we want to make sure that we don't pressurize this structure, because if it pressurizes, we're going to find it's going to collapse that urethra, and then you'd never get ejaculate coming out. So we need to make sure that we don't pressurize the corpus spongiosum so much that we collapse the urethra that's housed within it. All right, so this is a really nice view, kind of getting a better 3-dimensional view. So we have our 2 corpora cavernosa. You can see here that the cavernous artery traveling through the center. It's going to deliver blood. We have septa that's going to divide the cavernosa into specific chambers. So this will fill and pressurize. We'll have a really thick outer covering. So you're going to push against and swell against a really thick wall, which is going to give that rigidity. And then below the corpora cavernosa is the corpus spongiosum with the urethra. So we're going to see that as we navigate toward the front of the erectile tissue, the spongiosum actually is going to expand. This is actually all spongiosum tissue, expand in what we call the glands of the penis. So it will house the urethra. So posteriorly, the spongiosum is going to be the bulb of the penis, and then anteriorly, it's going to be the glands. So the spongiosum is going to have 2 swellings, an anterior swelling, that's the glands, and a posterior swelling, which is the bulb. All right, so this is a really nice view of that. We have this in the cadaver collection. So you can see in red, this is the corpus spongiosum. We can see here, here's the bulb of the penis. So this is where we're going to find the penile urethra is going to enter into this erectile tissue. It's going to travel through it to the front and expand as the glands. The corpus spongiosum, or the corpus cavernosa, are really what give the length and rigidity to the erectile tissue, and they're the ones that are going to anchor against the body wall. So posteriorly, they're going to expand as what we call the crus. Crus means legs, because remember you had curl or crus. So we have the legs here, they're going to expand and attach to the pubic rami on either side. So they're literally tethered with connective tissue. So when we start to pressurize them, they're going to push forward off of the pelvis, and that's going to increase the length of the erectile tissue. The problem for the erectile tissue is we don't want to pressurize the spongiosum. So what's going to happen is as the corpora cavernosa are pushing forward, we're going to put a cap of spongiosum tissue over the top of it. So as the cavernosa push forward off the pelvis, it's going to push the glands forward, and that's going to pull the corpus spongiosum. So the reason the spongiosum will be able to extend the length of an erect penis is because it gets pulled by the cavernosa, which is like kind of a really cool idea. So the cavernosa is going to attach to the pubic rami on either side. It's going to push forward off the pelvis. The glans is this anterior swelling of the spongiosum, which houses urethra. It's going to cap over the corpus cavernosa, and it's going to push essentially the glands forward and pull the spongiosum and the urethra, so stretching it. All right, and so that's kind of what we can see here. Here's that spongiosum tissue traveling on the undersurface all the way out to the anterior edge, and here it expands as the glands. Let me think. Oh, and when, erectile tissue is actually erect, so if you have an erect penis, you can actually feel the soft inferior spongiosum tissue housing urethra and the two large cavernosa sort of columns. All right, and then last is the prepuce or foreskin. Normally, if you have an uncircumcised male, the skin over the shaft or the body of the penis is attached to it. I mean, it slides back and forth, but it's attached. It's attached right at where the glans is located, and the foreskin is actually movable. So you can push the foreskin back or pull it over the head of the glans. During an erection, if you have foreskin present, when the cavernosa tissue pushes forward, it literally will pull the foreskin off of the glans, and that helps to stimulate the glans more easily, and also keeps the glans from getting cornified or thickened. If you've been circumcised, they actually cut right along the edge of the glans the foreskin off. Obviously in anatomy, every structure for the most part has a function. And so without the foreskin, the glans becomes a little bit less sensitive because it gets a little bit more cornified as it is exposed. One of the arguments for foreskin is that if it's present, you have the opportunity for bacterium to kind of reside within these recesses. So you have greater chances of sexually transmitted diseases sort of residing within the male foreskin. But adequate hygiene would prevent that for the most part.